marvelous. I mean, again, my brother and I lived together in the dorm. We uh, we pooled our resources. Our parents used to give us the money for tuition at the beginning of the year, so we would buy a car in the fall, sell it in the winter to pay the second semester. So that meant that we offered a lot of rides to friends, usually the shuttle to Wellesley. And so it was a good experience socially, academically. It was wonderful faculty, some of whom I'll always remember. Um, and the beauty of the Harvard Medical School is the fact that it's affiliated with a number of hospitals, all of which are equal, which means, in a sense, that the Department of Medicine, which was my interest, was very strong, whether I took something at the Mass General or the Peter Brigham or the Beth Israel or the Boston City. And it just meant you could learn about renal disease or pulmonary disease or heart disease in 4 different places with diversity of opinions. And so the education, I thought, was wonderful. In a sense, the high point of my medical school was being accepted into the Mass General house staff program, which was one of the 2 or 3 most competitive in the country. And that was a time when there were 12 interns, not 68 or 70 as there are now. And I had very much hoped that I would be selected for that program, and so I was very happy to be a house officer there with 11 other people who I felt were extremely able and enjoyed being with. Very importantly, in terms of the evolution of my thinking, what I would do with my life, I had clearly envisioned originally having an education at the Mass General, doing some science, and having an academic career in medicine. And just at the beginning of my second year, my assistant residency, the last polio epidemic hit, which was 1956. And Walter Bauer, who was the chief of medicine in July of that year, asked me not to go on my holiday as planned, but to stay and start to take care of the excess polio patients. To explain that, in Boston, none of the Harvard teaching hospitals took polio patients in 1956. We diagnosed them in the emergency room and then sent them either to the Haynes Memorial Hospital, which was the infectious disease hospital, or to the Boston City Hospital. The epidemic in '56 was such that those 2 institutions became full. And to the great credit of the Mass General, it then volunteered to accept polio patients for the first time. However, there was no faculty with experience in managing polio. So 2 of us who were assistant residents were assigned to admit the polio patients and obtain advice from a chap called Lou Weinstein, who was the head of the Haynes Memorial Hospital, where they had a vast experience, and also from a neurologist at the MGH named Ray Adams. And very quickly it turned out to be a very severe epidemic. And so the 2 of us, rather than taking care of all the polio patients, ended up taking care only of those who required an iron lung or a tracheostomy. That is, they either had polio that affected their lung function or their swallowing function. And that population grew so that the MGH then assigned an entire floor of the White Building to the iron lung unit, which the 2 of us were responsible for. And within a week or 2, the mandate went out that no physician could write orders on the polio patients except for these 2 house officers. And so that was a phenomenal experience, and it lasted from July to November. But during that time, I was very distressed when patients in an iron lung who were basically my age group died, since I had had severe paralytic polio and had had such a good outcome. So we assembled a group of people to try to help us understand why they were dying. And one day, I noticed when we took a patient who was in vascular collapse out of the iron lung to change the linen and breathe them by hand, that the color of the patient improved greatly. And so I then measured an arterial oxygen and appreciated that the patient was actually without adequate oxygenation in the iron lung, but with positive pressure, breathing with an anesthesia machine, oxygenated perfectly well, and the blood pressure returned to normal. That then resulted in a paper in the New England Journal of Medicine really describing the fact that this vascular collapse in polio was due to a ventilation perfusion failure and not due to the virus in the midbrain or some other reason. And it meant that we managed those patients differently. The reason I spend time on that is at the end of the 2 years, I had an obligated military service. And as it turned out, I was the only one of the 12 who had not applied to the NIH. So I was headed to the military. And when I completed my basic training at Fort Sam Houston in Texas, and the nice sergeant who was doing our assignments looked and saw that I had 3 papers in the New England Journal of Medicine, the sergeant decided I might have potential as a scientist, and rather than assign me to overseas, I was assuming it would be South Korea, sent me to the Walter Reed Army Institute of Research, where in turn they assigned me to the one immunologist that the Army had, at a time when the NIH did not have an immunology program. So the reason I'm spending time on that immunologist was named Elmer Becker, and it was really Elmer Becker and working with him during those 2 years that made me appreciate that I wanted to specialize in immunology. I was headed back to the MGH to be what's called a senior resident after my 2 years in the military with Dr. Becker, but he, appreciating that, began to make arrangements for me to have a second fellowship in England with a beginning immunology program at their National Institutes of Health when I completed my senior residency at the MGH. However, because of my work with Dr. Becker, I was actually able to get my first NIH grant in 1958 and have a lab and a technician during the time that I was a senior resident for that year. And then I went to England for 2 years to work in the laboratory of John Humphrey at their National Institutes of Health. And at that time, there were 2 other well-known immunologists rotating through there as well, Hugh McDevitt and Emil Unanue. And each of us ended up spending our lives working on the projects that we started during our time in John Humphrey's group during that 3 or 4 year span. I then returned to the MGH to be a senior resident, which meant I had 4 clinical years. And that was a very serious clinical year because we were responsible at that time for the emergency room and for the overnight ward. And so on completing that, I wanted to take a 3rd fellowship, and so that's when I went to Johns Hopkins to work with Manfred Mayer. But because I'd had 3 different postdoctoral experiences really over the years, my laboratory training took just as long as the clinical training, and so I entered really the faculty probably 8 or 9 years out of medical school. But my time with Manfred Mayer at Johns Hopkins was shortened because when Dr. Bauer, who was my chief of medicine at that time, went into pulmonary failure, because of my experience in the polio epidemic, he wanted me to come back. And so the polio business is a remarkable thread in my life. It's what caused me to choose or to think seriously about medicine and become a quality student instead of a haphazard student. It allowed me to make the observations that ended up with my assignment to Walter Reed and the introduction to immunology. And it just profoundly influenced a lot of things in my life that turned out to be good, really good fortune. And later on, there's a third piece to that I'd almost forgotten. When Dr. Bauer died, he was then replaced as chief of medicine by Robert Ebert. And Robert Ebert came to the Mass General from Western Reserve University, and he knew a good deal about inflammation. And he then looked at my interest in immunology, my experience in infectious disease, my experience in the respiratory area, and he moved me from the infectious disease unit to be head of the lung unit at the Mass General. And then when he became dean, he was the one who prompted me to move across town to the Brigham to really do two things, to teach immunology within the microbiology department, but to develop really an immunology capability at the clinical and research level for the school. And that then became a very important next step in my life after I completed my training.